Last week, we briefly introduced some of the effects that posture and position can have on the shoulder. In this video, we're going to explore some of the basics of scapular and shoulder function. 3 points we'll cover are basic anatomy, orientation and alignment, and muscular function. After covering these basics, we'll apply these concepts to our case from last week. To begin, the scapula, commonly known as the shoulder blade, rests on the back side of the rib cage, forming the scapulothoracic joint. If the position of the rib cage is altered, then the position of the scapula and its muscular attachments will be affected. Normally, the scapula is held generally flush against the rib cage via muscular attachments of the serratus anterior, rhomboids, and middle and lower trapezius. Muscular imbalance, weakness, and/or dysfunction can negatively affect scapular orientation and movement. Such issues can be influenced by ribcage position, but can also occur independently. The scapula also articulates with the clavicle and the upper arm at the acromioclavicular and glenohumeral joints, respectively. Scapular mechanics at the acromioclavicular joint play an important role during movement of the upper extremity. Motions of the scapula at the acromioclavicular joint include internal and external rotation, anterior and posterior tilt, and upward and downward rotation. In addition, scapular protraction and retraction respectively involve internal and external rotation in order for the scapula to follow the curvature of the rib cage. Similarly, scapular elevation and depression are respectively associated with anterior and posterior tilting for the same reasons. Let's review what we've covered so far about scapular orientation and alignment. Muscular attachments hold the scapula generally flush against the posterior curvature of the rib cage. This relationship can be affected by position of the rib cage and/or muscular imbalance, weakness, and/or dysfunction. Movement of the scapula at the acromioclavicular joint is important for proper scapular orientation during movement of the upper extremity, and includes the following 3 pairs of motion: internal and external rotation, anterior and posterior tilt, and upward and downward rotation. Because the clavicle also connects to the sternum, scapular motion may also be associated with movement at the sternoclavicular joint. We can now look at the effects on the glenohumeral joint. The glenohumeral joint is comprised of the glenoid fossa, which is housed on the scapula, and the head of the humerus, or arm bone. The glenohumeral, or shoulder joint, is described as a ball and socket joint because of the shape and interface of the articulating surfaces. The glenoid fossa, together with the glenoid labrum, comprise the socket portion of the shoulder joint. The head of the humerus is the ball portion of the joint that fits into the socket. Unlike the hip socket, the socket portion of the shoulder joint is quite small relative to the ball portion it articulates with. While such an arrangement allows for a great amount of mobility, the articulating joint surfaces do not provide a high degree of stability compared to a joint such as the elbow. The rotator cuff is meant to provide stability at the glenohumeral joint by compressing the humeral head into the socket during static and dynamic actions of the upper extremity. The muscles which comprise the rotator cuff attach to both the scapula and the humerus. All athletes need some combination of mobility and stability at the shoulder. Athletes that work overhead need large degrees of shoulder mobility and stability to ensure proper mechanics, maintain tissue integrity, and maximize strength and power production. Strength and conditioning programs should not only develop requisite levels of mobility and stability required for the sport, but work to increase the level and robustness of athlete performance. With these basics in place, we can now revisit our case from last week. If you recall, the position of the scapula is influenced primarily by ribcage position, muscular attachments, and articulation at the acromioclavicular joint. It follows that if scapular position and thus function is altered, then shoulder joint and rotator cuff function will be affected as well. Panels 1A and 1B nicely illustrate the effect of ribcage position on scapular position, while panels 2A and 2B demonstrate the effects of scapular orientation on glenohumeral joint function. In the panels on the left, the athlete's right rib cage is positioned down and forward relative to a neutral position as exhibited on her left side. The panels on the right show the athlete after performing a specific breathing exercise to reorient the right rib cage to a more neutral position. As you can see in panel 1B, neutral rib cage position was slightly restored. As a result, scapular position and glenohumeral joint function improved as shown in panel 2B. It is worth noting that normal end feel of shoulder internal rotation was also restored after the intervention. Now that we've seen the effects of position on mechanics, let's look at positional effects on muscular function of the rotator cuff. Part of our assessment includes evaluating isolated and integrated muscle function through a combination of manual muscle tests and integrated movement evaluations. Seeing as this athlete is a weightlifter, rotator cuff function and strength are vitally important. Here, we see manual muscle tests of the infraspinatus and teres minor before and after the breathing exercise. Compare the performance of her left and right sides. Note that her right arm is very jerky at the onset of resistance, and the rate at and degree to which it gives is significantly greater than the left side. After the intervention, her performance is smoother, and she is better able to resist the applied force. Obviously, she didn't get stronger during the 2 minutes of intervention, but she was able to express more strength as a result. By improving her ribcage and scapular position, she improved shoulder mechanics, demonstrated greater levels of usable strength, and resisted the same load with less effort. All of these effects will directly benefit her in training and competition by increasing safety, training loads, and work capacity. We've written before on the 4 main categories that influence movement: posture and position, musculoskeletal factors, neuromuscular and physiologic factors, and motor control. Our case today is a great example of the influence of posture and position on movement. It is important to understand the complex dynamic that these categories can have, which is why we're excited to offer our Movement, Strength, and Mobility seminar. In addition to learning the details and relationships of these 4 categories, coaches and athletes will learn how to incorporate assessments and corrective exercise within a performance setting to create more effective warm-ups, training plans, and competition strategies. There's also a hands-on session where we'll go over ways to address mobility issues affecting the ankles, hips, and shoulders. To book our seminar or for more information, visit our website at 5ringsathletics.com.